real-world evidence is something that we wrestle with because we have two different requirements or two different pathways. On one hand, we have to provide very detailed scientific evidence for the regulatory bodies, and that often doesn't represent real-world evidence. However, the payer very much wants to know how is this going to work in the real world, not in the investigational setting. So sometimes you have to do two different things, and that's one issue about real-world data. I guess the other issue, though, is the fact that the decision makers have changed over time. Remember, it used to be that you got regulatory approval, whether it was FDA approval, CE mark in Europe, shown it in Japan, and then you marketed the heck out of your stuff to doctors, and just to doctors, because they were the decision maker. And now you have a combination of decision makers. You have doctors, you have hospitals, they're the ones who buy the products. You have employer groups, you have payers. All of them are involved together in making decisions. So working with those decision makers as a group has become a bit more complicated, but I think that ultimately providing real-world data is what's important to all of them. So I think things are moving in the right direction. We're evolving towards a goal of increasing access to healthcare, improving quality, and reducing cost. And whatever we can do to address one, two, or all three of those things is going to be in the best interest of all of the stakeholders. So you see things like accountable care organizations. They're trying to address both quality and cost. You see a variety of other initiatives that Medicare is putting forth. They're all addressing either access, cost, or quality. In terms of communicating the information, there are a number of different initiatives that people are looking at. For instance, CMS now has a pilot program for parallel review, whereby you're sharing information with the regulatory agency, the FDA, simultaneously with the payer, CMS in this case, or at least one payer, CMS. I think that the earlier that you can talk to payers, the earlier that you can have a discussion with them, even about the design of your clinical trial before it begins, to see if the endpoints that you're looking at are going to be satisfactory for them and not just for the regulatory agency, whether it's the FDA or a national body in some other country. The idea of trying to speak with them and communicate with them early enough about what you're working on is going to possibly help in the long run, rather than just doing it all and then saying, here, this is what we have. Payers, hospital folks, industry are getting together, agency folks are getting together and talking to each other and understanding that we're all in the same boat. We're all in the same sandbox. We're all in healthcare, and it's not like one is the dark side and one is the light side. So I think people are starting to get that idea that we're all in healthcare together. We're all in the same sandbox. We shouldn't be throwing sand in each other's eyes. And I think things are getting better in terms of communication between industry, payers, purchasers, physicians, etc.